For years, a woman whose only risk was a previous spontaneous preterm birth, a normal cervix, nothing else wrong, had a drug we believed would protect her next pregnancy. Today, she does not. And the story of how we lost it is worth telling in full, because each step corrects a different way that medicine fools itself. A name gets mistaken for a molecule. A single striking trial gets mistaken for proof. A signal in weak studies gets mistaken for a real effect. All three run through this one drug.
Begin with her, because her risk is real and specific. A prior preterm birth is the strongest predictor of another. And the risk climbs with three features of her history: how many, how early, and in what order. From a large cohort of third births, the pattern is clean. 2 prior term deliveries leave her at about 5%. 1 prior preterm birth raises that to somewhere between 13 and 21%. And the order matters. A preterm birth in the most recent pregnancy weighs more than one further back. 2 prior preterm births push her to around 40%. And when both came very early, before 32 weeks, her risk of a third early birth reaches about 57%. That gradient is steep. 2 women can each have had a prior preterm birth and still sit worlds apart on it, depending on how early that birth came and on who she is. And the 2 trials in this story enrolled populations from very different places along it. Reading them apart is how the whole thing resolves. Carry the percentages as the shape of the risk, not fixed constants. And remember that this is the woman a preventative drug was meant to protect.
The drug that seemed to answer that risk arrived with the Meis trial in 2003. Women with a documented prior spontaneous preterm birth were randomized to a weekly injection, 250 milligrams of 17-hydroxyprogesterone caproate into muscle from around 16 weeks until 36. The result looked decisive. Preterm birth before 37 weeks fell from 55% on placebo to 36% with the drug. Before 32 weeks, from about 20% to 11%. Only 5 or 6 women had to be treated to prevent 1 early birth. On the strength of that single trial, the weekly injection became standard care across the United States. And hold that phrase, a single trial, because everything that follows is about what one striking result can and cannot carry.
The first crack appeared in the molecule itself. It is tempting to say the injection failed because it is synthetic, but the vaginal progesterone we trust for a short cervix is also made in a factory, so that word explains nothing. The real difference is structural. Micronized progesterone is progesterone, the identical steroid the ovary and the placenta release. 17-hydroxyprogesterone caproate is a different molecule. Its backbone is 17-hydroxyprogesterone, a natural steroid, but one with only weak progesterone activity. And onto it, chemists attached a caproate tail, a 6-carbon fatty acid the body never makes, whose whole purpose is to let the drug linger in muscle for a week, so it can be given as a single weekly shot. But convenience is not activity. What matters for preventing early birth is mostly the cervix, and there the 2 molecules part ways. Vaginal progesterone slows a shortening cervix, while 17-hydroxyprogesterone caproate has never been shown to change cervical length at all. On uterine muscle, the contrast is just as stark. Progesterone quiets it, the caproate does not, and at high dose, it makes the muscle contract harder. So this compound was engineered to be easy to give, not to reproduce what progesterone does to the cervix and the uterus. That does not by itself prove it useless, but a drug with no demonstrated action on the very organs that matter should, if anything, work the same little bit in every woman. Hold on to that, because it decides the case in a moment.
For 17 years, no confirmatory trial came, until PROLONG, reported in 2020. It was built to confirm Meis, deliberately. The same weekly injection, the same entry criteria, this time across 93 centers and more than 1,700 women. It found nothing. Preterm birth before 35 weeks was 11.0% with the drug and 11.5% with placebo, a relative risk of 0.95, and the newborn outcomes were no better. The trial built to confirm the drug erased it. Now, the question that has to be faced: how could the same drug, given the same way, look decisive in one trial and do nothing in the next? The answer is that the two trials enrolled populations at very different levels of risk, and once you separate them, both results make sense. PROLONG enrolled the common case, women with a single prior preterm birth. Before 37 weeks, its placebo group delivered early about 22% of the time, right at the upper edge of where the gradient puts a woman with one prior birth. So PROLONG tested a large, representative version of the ordinary patient, 1,700 of them, and the drug did nothing. For a woman with one prior preterm birth, that is the answer, and it is a clean and trustworthy one. The injection does not help her.
Meis had enrolled a far heavier population. Its women, like PROLONG's, had a prior preterm birth, but the deliveries that qualified them had ended on average at 31 weeks, early and severe. And the cohort was high risk in other ways, too. American academic centers, more than half the women Black. On the gradient's own terms, how early that prior birth came, on top of who these women were, that puts them far up the risk scale, even though most carried only a single prior. And the placebo group bore it out by delivering early 55% of the time. So Meis was not testing the wrong, low-risk women. Its population was genuinely high risk, and within it, the drug appeared to work, with a number needed to treat of only 5 or 6. That is the uncomfortable part of the story, and it has to be faced rather than hidden. The one population in which this drug ever looked effective was a real high-risk population.
So why don't we trust that result? And why don't we still give the injection to the highest risk women, the ones Meis enrolled? For 3 reasons. And the important thing is that not one of them depends on how sick the women were. So all 3 hold at the very top of the gradient, just as firmly as anywhere else. First and heaviest, there is no mechanism. The molecule does not act on the cervix and does not quiet the uterus, so there is no way it should help the highest risk woman that it doesn't help everyone. And in the ordinary women PROLONG tested, it plainly helped no one. Second, the Meis trial had a flaw in its own randomization. Its placebo group happened to carry more prior preterm births than its treated group, a head start that would inflate the drug's apparent benefit. Third, both the drug and the placebo were suspended in a castor oil vehicle, and a progestin's effect is known to depend on the oil it rides in, so the placebo may not have been truly inert. A single trial, never repeated, of a drug with no mechanism, its randomization tilted toward the drug and its placebo perhaps not inert, that is not a foundation on which to inject any woman weekly for half her pregnancy, however high her risk. When the regulators weighed exactly this, they judged it too thin and withdrew the drug. We should be honest that no clean trial ever tested the highest risk women on their own, but with no mechanism and a failed confirmation, there is no reason to expect it would have helped them, and every reason not to reach for it.
That leaves the obvious rescue. If the injection is gone, does vaginal progesterone, the drug that genuinely works for a short cervix, help the woman we started with, the one with a prior preterm birth and a cervix that is still long? Pool every trial, and at first it seems to. Early birth drops by about 1/3. But follow that number down as well. Sort the trials by quality, and the benefit belongs entirely to the small ones. 6 of the 7 small trials carried a high risk of bias, and the loose ends of a small, weekly run study almost always flatter the treatment. Keep only the large, carefully conducted trials, and the effect is gone. The relative risk sits at essentially 1. A benefit that lives only in the weak studies and dies in the strong ones is an artifact of the weakness itself. The same caution Meis teaches, in a quieter key.
So where does that leave the woman we began with, whose risk is her history, not a cervix anyone can see shortening today? Honestly, in a harder place than the confident version of this story admits. Vaginal progesterone acts on a cervix that is physically shortening, so it has something to offer her only if and when her risk shows itself that way. The guidelines build the plan around exactly that. No injection, and instead watch the cervix across the mid-trimester. And the moment it shortens, treat, because at that point she becomes the short cervix patient the strong evidence actually covers. But be honest about the gap that surveillance leaves. If her early birth is coming by a path that never shows as a short cervix, watching the cervix will not catch it. And that gap is widest for exactly the highest risk women, the ones Meis enrolled, most of whom will deliver early one way or another, and for whom watching a single organ is the thinnest kind of protection. That is the real state of the field, and she deserves to hear it plainly rather than be reassured past it.
Step back, and the arc is 3 corrections, each worth keeping. A name was mistaken for a molecule, and the molecule, a fatty acid ester of a weak steroid, was never shown to do to the cervix or the uterus what progesterone does. A single striking trial was mistaken for proof. A lone, unrepeated result, tilted toward the drug and unsupported by any mechanism, was allowed to become standard care before a second trial and the regulators found it too thin to hold. And a signal in small, weak studies was mistaken for a real effect. What survives is a rule honest about its own limits. For a woman whose only risk is a prior spontaneous preterm birth, with a cervix that is still long, we have no progesterone with trustworthy evidence that it prevents her next early birth, and no reason to expect one, even at the highest risk. What you owe her is watchfulness of the cervix, which we can act on, and honesty about the risk that watching may not catch.